So in terms of preparedness, the first thing that we need to understand, and we frequently forget that in our discourse, is something called resilience of a health system. Now, and the resilience of the health system is integral to our response in good times as well as bad times, like the one we are facing right now. We measure that by the resilience dividend. That is the ability of the health system to respond effectively during normal times, as well as its ability to, respond during bad times as well. Now, in India, the resilience dividend of our health system is extremely poor, barring a few states. And if you see in the fifth largest country of the world where I'm sitting right now, Uttar Pradesh and Bihar and the other empowered action group states, it's actually very, very poor. Now, when your health system is very poor, you cannot really respond to a pandemic of this scale. That would be a problem. There are two key health problems of our health system. One is our unhealthy and extreme dependence on a poorly regulated private care that cannot respond very effectively in pandemics. And two is, and this is more about general health, is our excessive inversion of pyramid of care, where we think that health is only hospitalization, where we think that access to health means access to health care or access to medical care. This is a problem. I will come to universal health coverage later. But I would like to draw a few points on laws related to health emergencies, basically. 3 points, basically. One is during this pandemic or during pandemics, what are our ethical considerations, especially in the context of the health system that we have? Second is, do we need legal reforms in health emergencies in our country? And third, and this is very important, is understanding the last bill, which could not become an ordinance up till now, which is public health bill. So, in public health, we understand that ethics is and should be a precursor to any law. That is the first thing that we have to understand. Sutton and others have written widely about it. Second is that ethics is integral to public health policy. And third, more importantly, ethics should not be limited to the content of policies, but also to the processes in which that policy will be implemented. One needs to understand that ethics change during pandemics because of two reasons. One, and which is very, very integral to COVID understanding. One is because uncertainty, skepticism, difference of opinions are bound to happen when you do not have full scientific knowledge, which will happen in every pandemic. And the second one is the trade-off between public goods and private rights. And the dilemma whether we should use more coercive policies or more voluntary public health issues. There are four primary ethical considerations in pandemics, as the World Health Organization also advocates, and that should be integral to our health emergency law as well. One is access to healthcare, and when we say access, we don't really mean that you have a health system but you can't afford it. So it's like Bernie Sanders used to say during his campaign that I have access to buying a $10 million house in New York, but it's not affordable. So that access is not the right word. So when we say access to healthcare, we mean with affordability. That is one. Two, the human rights angle during pandemics. Third is the obligations to and of health workers. What do they need, and how do we provide those obligatory requirements to them? And fourth, very importantly, is obligations of countries and intergovernmental organizations, whether they are doing that or not. So that was my first point in any health emergency law, that ethics should be a precursor and should be applied to processes. The second point that I want to raise on health emergencies is, do we need legal reforms for health emergencies in India, especially in our context of the health systems? Yes, because right now we are completely inadequate in terms of legal public health framework or law that can support us. And it's a clear answer during this COVID pandemic, where we are saying that the central government had to invoke two laws, and which I'm sure you would discuss in depth later on as lawyers. One was Epidemic Disease Act 1897, and the second one is Dr. Sarkar has done a lot of work on that, Disaster Management Act 2005. Now, I'll give you just one big problem that we have with Epidemic Diseases Act. We know that it was hurriedly prepared during the Bombay plague, because the British government wanted that everybody should migrate out of Bombay who are not the resident, and nobody should come in. It's one of the shortest sections of Indian Acts, 4 sections, and the problem is that it does not define an epidemic. There's no definition. Leave alone the process on how it will be defined. Then it says that you can adopt these measures or any measures for the prevention of the outbreak of a dangerous epidemic disease. One problem, we don't know what an epidemic is. Second is, who will define dangerous? I'll give you one example from healthcare, and which will be very clear. HIV/AIDS, the disease in India, is an epidemic. By definition, it is an epidemic, and there are 3 kinds of epidemic that we have present in our country. So it is an epidemic disease. Everybody agrees that HIV/AIDS is a dangerous disease. Does that mean that we can invoke any measures or travel restrictions against them? Or of course, if measures against the core targeted groups? No, nobody agrees with that. So Epidemic Disease Act is actually something that should have been, we should have been done with this law, and we've been trying to do that, as we'll discuss later. So there is no mention of air travel, for example, which is one of the biggest problems in COVID. So the government had to invoke EDA 1897. The second thing is the government had to invoke Disaster Management Act 2005. It is relatively new, but it's not about any disease. It's not about epidemics. It's about disasters. The problem is that it is completely non-nuanced. We cannot take, we should not be applying that to a disease in the first instance. It's very non-specific to epidemics as well. So by definition, if you are including epidemics in this disaster, as we have already, anything can be included then. So there's no difference if we keep on doing that. Also, if this crisis overgrows, then the Disaster Management Act 5, because it's not meant for that, does not have the necessary framework to actually control further actions apart from the ones we've been doing right now. Third, on health emergencies, is understanding the last bill, Public Health Prevention, Control and Management of Epidemics, Bioterrorism and Disaster Bill 2017, which was not passed. It was made by the UPA government, and in 2017 also came. And there are few experts from the opposition who are saying that make it an ordinance right now, and it would help us acting against the COVID. We disagree. I myself disagree, and many civil society organizations such as Jan Swasthya Abhiyan and WaterAid had actually pointed out that there are huge problems with this bill. Now, the huge problems are, one, we're calling it a public health bill, but it's not about public health. It's actually concentrated only on epidemics, and mostly on bioterror and chemical weapons and other epidemics. There are 2 things here. One is public health, and the other thing is public health emergency. If we are going to pass this bill by this title, then our public health, it has nothing on general public health. So that needs to change. Either we need a more comprehensive bill that talks about public health in general as well as health emergencies, or we make 2 bills, or you would know how to go about it. But it's largely a disease emergency bill. Now, if it is an emergency bill, what is the problem in it? Number one, every epidemic does not need a new law. A new law, or invoking a new law, would be related, not in an, would be used or important, not in an epidemic, but in an emergency where normal laws cannot take place of that. So we call it the 3 epidemic hallmarks of an emergency: that there should be exigency, there should be calamitous harm, and third is there is an unavoidability of harm through ordinary processes, and then you can invoke this law. Now, these epidemic hallmarks have not been defined in this ordinance, the public health bill. We do not even know what would be the process, who will declare an emergency, Who will check whether there are these hallmarks present or not? There's nothing mentioned that. So again, from my first point, the processes that would have recommended, and these were the processes as the World Health Organization has. So public health emergency of international concern, when they defined it in January and later February, the emergency provisions are also not really, they have problems of their own. The other point with that bill is the role of the center appears to be central in the bill, with little involvement of the state and district, and the state is health is a state subject, and therefore for effective coordination, and this is something that Love Agrawal was also saying, that we have laws enough, but the coordination is missing. Although we saw a fantastic coordination in terms of the Home Ministry not interfering with the Health Ministry during this, in terms of law strictly. The other thing is the responsibility of the government is not mentioned. It arbitrarily gives powers to the district officials and local authority. The practice guidelines are not mentioned. So the detail to the processes is missing in that bill, and this is a big problem. The other thing is that the patients' or citizens' rights have largely been ignored. There is no provision for legal recourse, no checks and balances on the implementation. And this is the most famous public health law expert in the world, Lawrence Gostin. He says that we need to remember, and we know this from the Black Death in Europe, that pandemics can be deeply divisive. It affects social cohesion, and the political response profoundly reflects the kind of society that we aspire to be. So the law needs to be tough on those aspects also and give value to patients or citizens. So the concluding remarks in terms of health emergencies is that it's like Mandeville's paradox. Actions that are vicious to individuals may benefit society as a whole, and that's why in public health emergency, we need proper ethics, we need to follow those principles, we need to agree with the Syracuse principles, and then only in the spirit of solidarity, coordination, and trust should we frame a law which is better than the law that we have we've been discussing in public health law. The second question, and the important question that you ask, is about universal health coverage political commitment. Now, the universal health coverage on paper appears very, very good. But again, the processes of universal health coverage is very, very varied. So if you see the universal health coverage in Thailand, it is actually very, very effective. But in Thailand, it is predominantly based on public provisioning of healthcare. In India and other places where we are trying this insurance-based system, it's not going to work. Insurance-based systems do not work because, number one, insurance-based systems, again, are only thinking of health as access to health care. And it's a hospitalization thing. So we think of health as a pyramid, where most of the patients should be treated at the lower level, at the sub-center, at the primary health center level. The patients who require further care, they migrate to the secondary care level, like the CHTs and district hospitals. And then if you're not well there, you're referred to the highest level of healthcare. Currently, what happens in India is everybody who has cold and cough thinks that he or she should visit a tertiary care hospital. There's excessive hospitalization-based system in India, which is very, very futile. And apart from United States of America, which is a very bad health system, there's no country in Europe where we have systems like that. We need to change the system, and for that, we need the primary health care. Unless and until the universal health coverage is based on a solid framework of primary health care, universal health coverage would not render a better health system. Because insurance, and that too with an unhealthy association with an unregulated private healthcare system, would be a problem. We need the private healthcare system, yes, but we need a stronger public health system, and then universal health coverage can actually make wonders, as it has done in countries like Thailand. So that is about the universal health coverage. The last word is about, we've discussed public health emergencies. The last thing that I would want to discuss is about public health law, where we really need to understand that this is not medical jurisprudence, and this is a very specific thing, where the primary objective of public health law is to pursue the highest possible levels of physical and mental health of the population, consistent with the values of social justice. And the greatest challenge in general public health law, not in emergencies, is the discourse between common and good. And this is a debate now all over the world, that things that are useful to the common public, for example, wearing seat belts or smoking in public, which is beneficial for population, uh, is common. But the good says, according to law, that the individual decision rights are paramount. And the problem that we have is the tragedy of the commons, that due to the good or individual rights, the commons sometimes suffer, as has been the case in the past in a neighboring country, that non-vaccination of polio vaccine renders the whole worldwide efforts futile. So this is the greatest problem and a critical challenge, that instead of coercive measures, public health advocates of public health, we make efforts to remove the distrust, to curb the misinformation and superstitions, and think of the common public as partners rather than enemies. Because risk sharing should be uniform and aspiration for good health is universal. So we should take advantage of that situation. This should be important for public health law. That is the only thing that I would say. Finally, on right to health, there is only one thing that I need to say, because you are all lawyers, therefore I won't fringe in. It is important to understand that when we talk about right to health, it should not be seen as right to health care alone. Because we have patients of anemia we see on a daily basis. 60 to 70% of our patients suffer from anemia. You cannot treat anemia sitting in an OPD and prescribing medicines. It's a structural problem of our health system, and unless and until there is a right to health, where we also take care of food and other things, right to healthcare alone will not solve anemia, no matter how much GDP we invest. Yes, our GDP investment is at the very, very poor. It's only 1.6%, which is very low comparison, which is minuscule in comparison to low income countries as well. And when NHP 2000 came up, 2002 National Health Policy during Prime Minister Honorable Atal Bihari Vajpayee, that policy said that we'll increase it to 2%. And then Vajpayee government was gone. Then came UPA. UPA 1 was gone. UPA 2 was gone. Modi government first came up, and the budget is already very low. Again, in 2017, the new national health policy says that we'll now make it to 2.5% by 2025. I don't think that is happening, because the annual increase is not present, and so we need that. So finally, strengthening of primary health care. Coming back to the non-hospitalized based healthcare, and right to health means not only right to healthcare, but all the other social determinants of health as well. Unless and until we have that holistic approach, talking about right to health would not really make the change that we want. So here on, I'll end my discussion. I'm very glad to listen to you. I would love to answer that question, Dr. Yazdani. So doctors are not gods. No human is a god. Gods are not meant to be on earth, number one. Number two, this is the biggest problem that we have, that we think of doctors as either angels or as robots. So one line of thinking thinks that consider them angels and say that, why are you not doing stuff that you're doing? And there would be no inquiry over them. There is no direct control over them, and give people choices, and everything is fair and fine because doctors are very ethical and all that thing. But they're not gods, they're not angels. The other line of thought is like thinking of them as robots, as many of the countries do, that you issue a guideline and they'll work on it. They don't need food, they don't need money, they don't need nothing else. So that is a very problematic perspective about that. The second thing, and that is extremely important, and this is related to the other question that Sanjay Hegde was answering on nationalization of healthcare. And the other question on privatization, a few of you might remember Jayant Shah, whose daughter died after 16 years during swine flu epidemic, a dengue epidemic in Delhi. And he became an activist, and he put up a case. 15 lakh rupees were taken by a private healthcare establishment because she stayed there for 8 days. He was asked this question on NDTV in a big panel discussion that आप भी तो गलत कर रहे हैं ना, आप तो गवर्नमेंट सिस्टम में गए नहीं, आप प्राइवेट सिस्टम में गए तो पैसे देने पड़े. And to that, Jayant Shah answered, and I still remember his answer, is that you stand on the street of Delhi and ask people which is the best hospital to go to, and everyone will answer AIIMS. ओके, बट द प्रॉब्लम इज कि मैं एम्स गया, वहां पर भीड़ बहुत ज्यादा थी, मेरी बच्ची को इमरजेंसी की जरूरत थी, मैं मजबूरी में इस प्राइवेट हेल्थ केयर में गया. द गवर्नमेंट कैनॉट एब्सॉल्व इटसेल्फ फ्रॉम दिस प्राइमरी ड्यूटी. इट्स नॉट ओनली अ रेगुलेटर, because health, security, and general public welfare is something that the government has to provide and not only regulate. This doesn't mean कि private systems नहीं हो, but public system जब strong होंगे तभी private system सही होगी. 30 years ago IIT बहुत strong engineering colleges थे, तो सारे private colleges भी काफी अच्छी quality के थे. आज की डेट में दोनों खराब हो रहे हैं. So we need very good public health system as well.